During our last session, Dr. Romano, Dr. Findley, and I spoke to the importance of MACRA to providers and what viewers can expect from this video series. This portion will focus on the history of healthcare reimbursement models to give some context as to how the industry arrived at MACRA and value-based payment models. I believe this is important to understand as a foundation. The history of legislation such as the Balanced Budget Act of 1997 and the resulting sustainable growth rate known as the SGR are precursors to the Physician Quality Reporting System, or PQRS, Meaningful Use, Value-Based Payment Modifier Program, or VPM, and the upcoming Quality Payment Program, or QPP, under which the Merit-Based Incentive Payment System and Advanced Alternative Payment Models, or APMs, are structured. These events in the timeline of healthcare reimbursement programs explain the CMS push towards value-based payment models over volume-based payment models. Let's start with the Balanced Budget Act of 1997. This act amended the Social Security Act to create the Sustainable Growth Rate Formula, or the SGR, the doc fix, which was meant to control growth in Medicare spending for physician services by establishing targets for total expenditures. The formula took into account four major items: the estimated percentage change in fees for physician services, the estimated change in expenditures due to changes in laws or regulations, changes in the average number of Medicare fee-for-service beneficiaries, and the estimated 10-year average annual percentage change in real gross domestic product per capita. While the SGR targets weren't actual limits on spending, if total expenditures for physician services for Medicare exceeded those targets, the physician fee schedule update was to be reduced. However, every year since 2003, Congress enacted a short-term legislative patch to delay the SGR cuts to the physician fee schedule. A critique of the SGR pointed out that tying payment increases to cumulative expenditures only encouraged providers to administer high volumes of services and disproportionately burdened those in specialties with little ability to provide higher volumes of care. This is the history of the volume-based care that we are working hard to move away from, as more care does not equal better care in the case of many patients in our country. It would just take us back to the years when the sustainable growth rate came into being. I was in private practice. We were operating on about a 5% margin in our practice. And what was it like those days, you know, as the annual rush to say, oh, the SGR is going to cut our reimbursement by X amount? And tell me where you were at and what was the experience of living through those years of the sustainable growth rate, or the doc fix challenges we had.
Well, yeah, I was in private practice just like you, Mike, and you know, when you're running your own practice, margins are thin. You know, we always tried to balance the government payers, Medicare, Medicaid, with the commercial payers. You know, it started to become a time where the margins on the commercial payers weren't enough to offset, and then suddenly the government says to you, we're cutting you 10, 15, 20, you know, as you look at it through the years and how ugly it got. And then you started to have to think, well, what am I going to have to do with this Medicare population? You know, this was a significant portion of your practice, obviously. And so you've got 30, 40% of your practice tied up, and you've never been in the habit of limiting access. And are we going to have to limit access just so we can keep the doors open? So yeah, at first it was this tragedy that was about to befall us. Eventually we got to the point where, well,
We
we
just
knew
ignored it.
Congress was going to fix it. So.
Yeah, they'll fix it. We got to the point, I think it was 15 or 17 years of us living with this, and we did get to the point where we say it fixes. But I'm curious, John, where you were at and what you recall about, particularly in the early years where the margin, the cuts just kept growing.
Yeah, I mean, I think you said it best. I don't know that I can add a lot to that. I think that the margins are tight in primary care, family medicine, that I felt like it was always just this sense of being out of control. There was always a little bit of angst and a little bit of fear about how deep were the cuts going to be. And as we all know, it's tough. That made me want to minimize access for Medicare and or Medicaid. We would always try and protect our borders, per se, which is entirely dismissive of patient-centered care, but it's one of those functional realities of how bad do we want the margin to be.
Yeah. Right.
Am I looking at pay cuts for myself and or my employees? And you would try and accommodate by messing with your rates with your commercial payers to make up for that difference. And I think that's one of those realities that this payment reform has continued to sort of under-acknowledge. Is payment in healthcare has been a lot of smoke and mirrors for a lot of years. And the SGR fix was just one of many elements that created a very convoluted approach. I think MACRA offers a more sensible approach, one that makes sense. I think it's the right thing to do. It really just felt random and scary.
Yeah. Over the next few years, CMS developed 3 value-based programs that affected physicians: the PQRS program, the Meaningful Use program, and the Value-Based Modifier program. These programs began providing an adjustment to a provider's Medicare Part B reimbursement based upon specific performance criterion. We will go over a quick summary of these 3 active programs, as it's important to know that all 3 will be rolled into MIPS as CMS transitions to the Quality Payment Program in 2017. The requirements in MIPS aren't exactly the same as the programs beforehand, and it will be calculated differently. We will discuss the evolved criteria under MIPS later, but for now it's important to know an overview of PQRS, Meaningful Use, and VBM, and understand that while they will sunset when MIPS is in place, the grading criteria will be measured differently. PQRS, the Physician Quality Reporting System, will be in place through the end of this performance year, that's 2016, with potential adjustments applied in 2018. PQRS is a reporting program that encourages individual eligible professionals and group practices to report information on the quality of their care to Medicare. This program gives participating providers the ability to compare and assess the quality of care they provide to national benchmarks and drives a pursuit for quality of care through reputational impact. By reputational impact, we mean that the quality reports are available to the public and peers on a CMS-sponsored website, and providers who are low performers or choose not to report on PQRS measures at all are subject to the reputational impact assessed by their patients and peers. It should be noted that PQRS is a penalty-only program, or otherwise stated as a penalty for not reporting the requested data. In payment year 2015, the program began applying a negative payment adjustment, negative 1.5% in 2015 and negative 2% since, to individual eligible providers and group practices who did not satisfactorily report quality measures to Medicare for performance years 2013 and later. You know, we're just talking about Medicare Part B with this legislation, but I'm curious what your perspective is. Is this value-based move to pay providers for quality and for the spend? Do you think it's just going to be limited to Medicare? or what? What are your thoughts about this trend in the marketplace?
I mean, I think we've all got enough gray hair on our heads to know that
Or no hair.
Or no hair.
Or no hair.
Yeah.
I didn't. Thank you, Mike. We know that private payers will follow suit. They always do. I mean, this is a proverbial chase that's gone on forever, that whatever Medicare does, private payers will basically replicate that to some degree or another. So I think it would be short-sighted to believe this is just Medicare, Medicaid, is my opinion. I think it's coming. I think what you look at the Blues are doing across the country, they've been pushing patient-centered medical home for some time now, which dovetails with much of what MACRA says to do.
Yeah. And I think healthcare across the board, whether you're dealing with government payers or whether you're dealing with commercial payers, has become unaffordable.
Yeah.
You know, we've all been faced with rising costs of our own healthcare insurance, and those rising costs are really driven by the costs that are being borne by the various payers that are out there. So this is a situation that can't continue.
Yeah.
I think all of the payers have started to realize that giving us gold stars for saving money or being cost efficient is not moving the bar very much, and that the only way they really get this done is to start having us share in some of the savings and ultimately some of the losses that occur.
Medicare Meaningful Use is both an incentive and a penalty program, in that providers who do not participate in the program or are not in compliance with the program, they will receive penalties. The key progressive phases of meaningful use are promoting basic electronic health record adoption and data gathering, the emphasizing care coordination and exchange of patient information, and third, improving care outcomes. A key characteristic of the Meaningful Use program is the all or nothing nature of compliance. A provider is deemed compliant if all measure performance rates exceed thresholds set by CMS, but no additional incentives are awarded for further improvements in measure rates. Even if one required measure fails to reach threshold, then the provider is seen as not compliant and will be assessed penalties. The last pay for performance program we will discuss to understand the context for our current reimbursement environment is the value-based modifier, or VBM, program. Starting in the performance year 2013, the value-based modifier program evaluates the performance of solo practitioners and provider groups as identified by their taxpayer identification number on the quality as determined largely by their submitted PQRS measures and cost of care they provide to their fee-for-service Medicare beneficiaries. The Centers for Medicare and Medicaid Services, or CMS, disseminates this information through confidential quality and resource use reports, or QRURs. For each TIN subject to the value modifier, CMS uses quality and cost data to calculate an adjustment to each TIN's physician's Medicare physician fee schedule. Adjustments can be made upward, downward, or remain neutral based on the performance relative to peers nationally. The value-based modifier program shows the movement to pay for value rather than volume by adopting PQRS measures as the basis for quality measurement and calculating quality scores based on comparison to national peer benchmarks.
You know, if we believe the idea that 20%, maybe even 30% of what we do is unnecessary or at worst wasteful, there is some margin there to cut back, and there's something to be gained. But I think there has to be incentives in place for physicians to look for ways of doing this, because we all know the big ones. You know, we all know emergency departments and readmissions and those sorts of things drive a lot of costs. But I fully believe in the collective wisdom of the physicians that once we get together and start to think about this, we'll come up with many more ways of saving cost and eliminating care that is not really necessary and valuable to
Well,
the
I think
patient.
that's been demonstrated. I mean, if you look at folks that really get into a patient-centered medical home model, it's a 20 to 30% reduction in ED utilization in outpatient services. And so we know these team-based models, data-driven, continuously improving, patient-centered models do in fact lower the cost of care. So we know, for example, Aetna, one of the largest national payers, has come out and said by 2020, 80% of our contracts are going to be value-based arrangements. And in the state of Nebraska, the Medicaid contract, by the third year of that contract, they have to have 30% of their payments tied to value-based arrangements. And so I really see this coming at us in all fronts, the commercial payers, the Medicare and Medicaid, and it isn't an early trend. It is a sea change of how we're going to be compensated on all fronts.
And I think what we have to remember is, at least over the short term, and the short term is how we're going to be judged by all of these various payers, is that the quality that we perform won't automatically result in decreased cost. So over the long haul, if you do all of the things and all of the necessary care for a population, that population eventually becomes less costly. But over the 1 year time frame that all of these payers are looking at you, performing high in the quality arena is not going to cut costs. And so we really have to, as we address it with our physicians, have this two-pronged approach. Very much about quality, that's for the future. Cost, short term, what can we save in a year?
It's important to understand the history of our healthcare industry's reimbursement models, as well as the current quality programs in place, as they lead to the major shift in payment structures starting in the 2017 performance year and the associated 2019 payment year under the MIPS and advanced APMs.